For the last years, we've been collecting more than 150 years of human knowledge, coming in the form of news articles, billions of tweets, millions of web searches, and applying artificial intelligence algorithms to read all of this information and create what we call a causality graph, a graph that represents everything that humanity knows about causality, 300 million nodes and billions of edges. The way the system was constructed, we built an AI system that can read sentences, identify who did the action, what was the action, on what it was performed, and when, and then look for cues that we as humans use to convey causality to one another. So in this case, the authors actually wrote that US Army bombs a weapon warehouse in Kabul with missiles will cause 5 Afghan troops to be killed. Armed with this knowledge, we started building systems that try to identify patterns of events before they happen. The system identified a connection between droughts, a year and a half later, storms and floods, and a month and a half later, cholera outbreaks. This happens in Africa, in Bangladesh, and in all of those cases, eventually leading to a cholera outbreak. The connection between storms and floods and cholera is a well-known one because cholera is a waterborne disease. But it wasn't well known that if you have a drought 2 years before those floods, the probability of cholera outbreak is extremely high. How high? In Angola, since 2006, all of the cases of cholera had exactly this pattern. In Bangladesh, since 1960 till today, 19 significant cases of cholera, more than 80% of them had exactly this pattern. But this pattern doesn't happen anywhere else in the world. It doesn't happen in Tel Aviv, doesn't happen in New York, doesn't happen in Vienna. How do we know where those patterns happen versus not? So we decided to give artificial intelligence systems more knowledge, word knowledge, so it can actually abstract and identify what's in common. Is this the area total, the ethnic groups, the government types? The system going through all of those billions of historical events identified that only 2 parameters actually mattered. The GDP of those countries, probably a proxy for sewage systems, and the second part is the percentage of water. We started building a system that scans news articles to start identifying the beginning of those patterns. In April 2011, our system picks up the following news article and starts alerting about a cholera outbreak in Cuba. We didn't pay too much attention to it because cholera didn't happen in Cuba for the last 130 years. But a year and a half later, the system picks up another news article about floods, alerts about a cholera outbreak, and indeed, a month and a half later, the first cholera outbreak in Cuba in 130 years. And cholera is a disease that kills 100,000 people every year, but it's very simple to treat. If you get clean water in time, mortality rates drop from 50% to less than 1%. And we started utilizing these systems with 8 organizations to know when to send clean water to be prepared for the next outbreak. But this wasn't a system only predicting cholera outbreaks. It was used to predict riots. We predicted the Sudan riots in 2013, genocides. There was more than 20 after World War II. But today, I'm focusing on a much bigger outbreak that we have right now. And no, it's not COVID. Today, we have almost 4 billion people without access to primary care. Do you know what it means? It means that today, 8 hours of waiting times inside the emergency departments in China. In Israel, it's 3.6. But it's very soon going to become exactly this number. We have a huge overcrowding inside hospitals. The population is growing, but we're unable to keep up with the pace. So we started collecting more than 100 million of medical records. Israel was lucky enough to start collecting this information for the last 30 years in digital forms. And we started building natural language processing systems that can read this information, identify patterns. And we started putting what we call AI stations inside the emergency departments in Israel, in Mayo Clinic, all across the world, where patients are waiting inside the emergency department. They're being asked a set of clinical questions, triaging, and identifying which task needs to be ordered, who's urgent, who's not. And today, we're bringing this information into primary care. Every time a patient, before seeing a physician, is being asked a set of clinical questions, predicts the tasks, and alerts physicians if there's something of higher urgency. But this is only when a patient has a problem. What I'm actually doing these days is trying to think, can we predict a problem with a patient before it happens? So what we're starting to do is look for 60 billion historical visits of patients with collaboration with large health plans in the United States. And instead of focusing on patients who are very expensive and trying to treat them in a preventive way, we're trying to identify the patients that will be sick, that are now deteriorating, and how we can actually intervene to stop this. We're treating more than 28 million patients monthly across the world, mostly in the United States and in Israel. And we're glad to share that after almost 2 years, we've shown that we're able to reduce by 2 times the number of inpatient visits of those patients, the number of emergency department visits as well, helping scale the healthcare system that we so desperately need to scale. Thank you so much.